cannulated, never throw the stylet away, because oftentimes you have to unclog the lumen. So typically what I would do is everything's going to be underneath the Mayo stand, and that's how it would be thrown off. This, often I would rest on my Mayo, but this is the #1 thing that they're using. Sometimes you'll have a separate, you'll have usually one suction, you guys, but sometimes they'll have you switch from the tonsil suction, also known as what? Yankauer suction, to the cobulator. So sometimes your job is to switch them. If you're doing that, make sure you're not switching and hitting the patient.
So when we put the suction, do we put our hands underneath the Mayo stand like you did, or?
Yes, actually, so this is that gray area of what is considered sterile, you know, because you can't see your hands. If you're going to do it, you know, some people that are going to be too technical will ask you to throw it off, or you'll do it before you put your Mayo stand on there. You'll see people do that though. Yeah, go underneath.
The last thing you said the Yankauer was being switched off with the cobulator.
Yeah. And also what you'll have too. You guys can play with it too. Hold on.
Do you get longer than 5 minutes on yours?
I'm at 14.
Mine only does 5 minutes at a time.
So this is called like the ear bulb syringe, or it's the sucker for the newborn babies. When you are doing a tonsillectomy, you are going to have ice-cold irrigation. What kind of irrigation?
Ice
cold. Ice cold. Okay, so then we typically will have ice-cold irrigation. Ice-cold irrigation is that irrigation is going to specifically be close to the heart room. Because what type of irrigation do you think they use in heart cases?
Ice cold.
Ice cold, yes.
Why is that?
Well, because when you're using something colder, what does that typically do?
Reduces
slows things down. You don't want the patient to aspirate, obviously. So you want to slow down the bleeding, slow down whatever, you know. Because the last thing they're going to do is actually, if there's a lot of bleeding, they're going to want to be able to slow down the bleeding, locate the bleeder, and buzz it.
And the patient will be intubated nasally?
Yeah, a lot of times it's going to be nasally. A lot of times also, this is why they consider it a clean case. They'll have regular general. So you'll have ET tube, endotracheal tube, in the field, usually on the side of the mouth. I know that sounds crazy. You'll have to see it to believe it, but yes, they'll usually either read in the side of the mouth, or they'll just do light IV sedation, so it depends. And then the #1 rule with any pediatric case, and the #1 pediatric case that you'll be seeing is tonsillectomies, is never disconnect the suction. Why do you think that is? I'm going to call my new person that I like to pick on. I'm going to call on Monique.
Why not?
Why do you think we never ever disconnect the suction until the patient leaves the room? They might need it again because why? You need to call a friend?
No, they already said.
Yeah. Because what?
Aspiration.
Yeah. Because there's a higher chance when you're working in the oral cavity that they're going to aspirate. So you never ever